Hello, dear student, and welcome to my second lecture, which is about local anesthetics. In the previous lecture, we talked about the anesthesia and stages of anesthesia, general anesthesia, and we defined anesthesia, and we defined general anesthesia, local anesthesia, and general anesthetics. And as well, we talked about the drugs which are used for general anesthesia. In this lecture, we are talking about the local anesthesia and local anesthetics. And I hope that at the end of this lecture, you know this table of context that I have written, and we will discuss about that in this lecture. First of all, we will have an introduction on local anesthesia, then we'll have a general concept of general and local anesthesia, then we'll talk about the features of local anesthesia and chemistry of local anesthesia and the difference between local anesthesia and general anesthesia, and then we will talk about the chemistry of local anesthetics and types of local anesthetics, which kind of local anesthetics do we have, and mechanism of action of local anesthetics and systemic intoxication. If they have, they will talk about that and different techniques of local anesthesia. So we'll talk about all these context. First of all, as we talked before in previous lecture, anesthesia generally divided in two kinds: general anesthesia and local anesthesia. And we talked about the general anesthesia. Today, we would like to talk about the local anesthesia and talk about all things that in previous slide we had the table of context, yeah? And what is the difference between local anesthesia and general anesthesia? So there is features in this column. There are general anesthesia, features of general anesthesia. In this column, there are the features of local anesthesia. So according to site of action in general anesthesia, the site of action will be CNS, central nervous system, but site of action for local anesthesia will be peripheral nerves. It will be in our hand, it will be in our finger, it will be in the penis, it will be in our foot. So it is peripheral nerve, but it is central nerve system. Area of body involved. In general anesthesia, whole body is involved, but in local anesthesia, just restricted area of body is involved. It is just a region, a local area of the body, a part of the body is involved in this anesthesia, in local anesthesia. And consciousness, in general anesthesia, the consciousness will be lost, but local anesthesia, the patient will be conscious, and all sensation of the patient is unaltered and it is not changed. The patient can talk, the patient can hear, the patient can speak, and care of vital functions. It is very essential in general anesthesia, but in local anesthesia, usually not needed. But if you do, it is good. In general anesthesia, why care of vital functions are so important? Because in general anesthesia, as we talked before, the respiration is ceased. The respiration is stopped. When the respiration is stopped, then we have to support it. We have to have an artificial respiration for the patient. We have to have supportive care for respiration and for circulation of the patient. If we don't have 8. General anesthesia even will cause death of patient. In poor health patients, the patients who has comorbidities or comorbidity condition like cardiac disease, like heart disease, like respiratory disease, like renal disease, like hepatic disease. So these patients will take anesthesia. General anesthesia will be risky for this category, but local anesthesia is safer for them. Use in non-cooperative patients, patients who are non-cooperative, patients who do not help the doctor, patient who does not help the anesthesiologist. So general anesthesia in this patient is a good choice. It is possible for them, but spinal anesthesia is not possible because you know that in spinal anesthesia the patient should be positioned. Yeah, for example, in sitting position or in lift lateral position. So the patient should has a good position. For example, in spinal anesthesia, patient should be cooperative. Patient should help the doctor if the patient is so weak, so old, or according to some stress, she or he cannot help the doctor. Then general anesthesia will be a good choice for the patient. For the major surgery, of course, general anesthesia is preferred, but local anesthesia cannot be preferred because for the major surgery, it will take lots of time. It will be a prolonged surgery. So, uh, in general anesthesia, we will maintain the condition, will maintain the anesthesia. But in local anesthesia, when we inject it, the local anesthetic after finishing the duration of action of our drug, then anesthesia will be finished, anesthetic effect will be finished, and then again injection, especially in spinal anesthesia, uh, will not be good for the patient. That is why it is preferred than minor surgery, I mean local anesthesia. So in minor surgery, local anesthesia is preferred, but general anesthesia is not preferred. Local anesthetics are medicines or drugs or agents when administered directly to peripheral nerve, it blocks the nerve conduction and abolish all sensations in the part supplied by the nerve without loss of consciousness. We talked about this before, so it will be a kind of definition for the local anesthetics. Of course, in local anesthetics, it is applied, not injection alone. Sometimes we'll inject local anesthetics, sometimes we'll just, it will be kind of spray, it will be a kind of pomade, and we apply it on the area that we want to do be without sensation. So there are some features of local anesthetics. These features are the good features, the positive features of local anesthetic, that local anesthetics should have these good features. But sometimes not at all, no drug is present till now among the local anesthetics to have all these good features. So we choose the drug which has the most of these good features. These good features or characteristics of local anesthetics are like this. Local anesthetics at first should have quick onset of action. When we inject it, after, for example, 30 seconds, after 1 minute, it should begin its action. Okay? Because if we inject it, we stay and we wait for onset of action of this agent, it will take times. For example, after 10 minutes, it will affect on the area that we injected or applied it. Second, local anesthetic should not be irritant to skin and mucous membrane. Of course, it should not be irritant. For example, sometimes we'll use it in in the mouth, we'll use it in the tongue, we will use it in the nose, in mucous membrane, in urethra. So if it is irritant, then it will cause some kind of uh, allergies or some kind of reactions in mucous membrane or skin. Duration of action must be long enough to allow desired surgery to be completed. Of course, some local anesthesia will take time, so it is necessary that the local anesthetics, duration of action of local anesthetics should be enough for doing that procedure. Should be effective on both injection and local application. Injection and local application. Local application means spray, and local application means pomade or gel. Should have low systemic toxicity. Of course, we choose the drug which is a low systemic toxicity effect. Should not cause any permanent damage on any tissue. It is a good feature. Should be relatively free from producing allergic reactions. Of course, uh, all drugs that we use in the body will create some kind of allergic reaction. But the best one would be the drug or agent which has the low chance of allergic reaction. It will be good. Yeah, should be stable in solution and readily undergo biotransformation. So, as I mentioned before, that no local anesthetic in use today satisfy all of these criteria. However, all anesthetics do meet a majority of them. Okay, let me translate. So, now we are talking about the chemistry of local anesthetics. According to the chemistry of local anesthetic, we have got two kinds of local anesthetics. In this chemistry, this side, one side is an hydrophilic amine, but the other side is a lipophilic aromatic. So these two sides should be linked with each other. This linkage, if done by ester, so it is called ester amine or amine ester, amino ester anesthetic. But if this is done, this linkage is done by amides group, then it will be amino amides anesthetic. Then according to the chemistry of these drugs, it is classified in two main parts. The first one is ester anesthetic and the second one is amides anesthetics. Let's talk about this. Ester anesthetics are like cocaine, procaine, tetracaine, and chloroprocaine, hydrolyzed in plasma by pseudocholinesterase, of course. But amides are lidocaine, mepivicaine, prilocaine, bupivacaine, and etidocaine, metabolized in the liver to inactive agents. True allergic reactions are rare, especially with lidocaine. So it is a good choice. I think amides are a good choice. It is better than ester, and we'll talk about the preference of this in the next slide. And an advantage of amide local anesthetics over ester local anesthetics. Of course, I told before that amide anesthetics are better than ester. So what is this advantage? Produce more intense and longer lasting anesthesia. We told that one good feature of local anesthetic should be this, that have longer duration of action. So amide anesthetics has this good feature. So it is better than ester. Bind to alpha-1 acid glycoprotein in plasma. So when it bind with that, when it goes to circulation and bind with another compartment or other protein inside the circulation, so the toxicity of these drugs will be low enough than ester anesthetic, rarely cause hypersensitivity reaction. So it is another good feature of amide local anesthetics, that low hypersensitivity reaction is recorded with amide anesthetic. According to classification, all local anesthetics, if it is amide or esters, are classified according to this group. Injectable anesthetics, uh, again, this injectable anesthetics is divided in three category. The first one is those anesthetics which has low potency and short duration of action. These are procaine and chloroprocaine. And the second one is intermediate potency and not short duration, intermediate potency with intermediate duration. It is not short duration. Okay, intermediate potency with intermediate duration, lidocaine and pyrrolocaine. They both has intermediate potency and intermediate duration. So if your procedure is not so short or not so long, then you can use these drugs, lidocaine or pyrrolocaine. If your uh, procedure is very short, for example, inserting a NG tube or endotracheal tube, so you can use this agent. But high potency and long duration agents are tetracaine, bupivacaine, ropivacaine, and dibucaine. These agents are used for especially for spinal anesthesia, because with spinal anesthesia it is a kind of local anesthesia. With spinal anesthesia we do very large operations, orthopedic operations, gynecological operations, urologic operations, okay, in the pelvis, even in the abdomen, even on the kidney nowadays. We do operations, procedures with these agents because it has a long duration effect. Surface anesthetics, those anesthetics which are used as a gel, as a spray, and as a pomade. Soluble, insoluble, water soluble, and water insoluble. They are like cocaine, lidocaine, tetracaine, and benzonate. In this insoluble, benzocaine, butyl aminobenzoate, and oxytazine. These drugs are used, for example, for inserting a Foley catheter for the patient, for anesthetizing of urethral mucosa, inserting of NG tube for the patient, for anesthetizing of nose mucosa, and inserting of or applying of endotracheal tube. Then we use the gel of these agents and drugs. What is the mechanism of action of these drugs? As you see in this picture, this side is out of the neuron, and this side is inside of the neuron, and this is cell membrane of the neuron. It is the membrane of the neurons. So in resting position, there is no any inflow or outflow of sodium. Sodium is here on the outside, and it does not goes inside the cell. It is resting membrane. When it is activated by the stimuli, for example, pain stimulus, then sodium will go inside to the cell. So influx of sodium inside the cell will activate the cell and create the action potential. So by creating action potential and activating the cell, then the impulse or the reflex or the stimulation will transmitted by the neuron to the central nervous system, and the patient will feel it. But when you apply a local anesthetic or even general anesthetic, but what is the difference? That local anesthetics just affect the peripheral nerve. Where do you inject it? Where do you apply it? But general anesthetic affect the central nervous system, but the mechanism of action are similar. It is the same. Uh, so anesthetics or local anesthetics, we are talking about local anesthetics here. So local anesthetics cause to close this door and inhibit influx of sodium inside the cell, even with stimulation. What is stimulation? Your blood. When you want to do a surgery, a procedure on the patient's skin, so when you cut or incise the skin of the patient, it is a kind of a stimulus. It is a very, very deep and powerful stimulus to create pain for the patient. But these anesthetics block this way, block the influx of sodium inside the cell and inhibit influx of sodium inside the cell. So by inhibition this, then the cell will not be activated and cell, even by stimulus, will be in the resting condition. So it is the mechanism of action of these drugs. So it has written in here, local anesthetic blocks the nerve conduction by producing entry of sodium through the reducing entry of sodium through the voltage gated channels. It is voltage gated channels that way I showed you before. Due to this, they block the initiation and propagation of nerve impulses, of course. At higher dose, it also blocks voltage gated calcium channels and potassium channels. So when you inject or apply the local anesthetics with a high dose, of course, it inhibit, it block the calcium channels and the potassium channels and cell membrane of neurons as well. So it will cause some difficulties for the patient, especially when your agent absorbed to the circulation, or the level of absorbed agents inside the circulation is high. It will cause some kind of toxicity, especially some difficulties in the cardiac action, the heart action, and even it will threat the life of patient. So what is the role of vasoconstrictor with local anesthetics? Vasoconstrictor use adrenaline, especially adrenaline is used as a vasoconstrictor with solubility of 150,000 to 200,000 solution. What is the role of this vasoconstrictor? What is the role of adrenaline when it is used with local anesthetics? First, it prolongs duration of action of local anesthetics by decreasing rate of removal from local site into circulation. So why it decrease the removal of local anesthetics from the site? Because vasoconstrictor cause the constriction of uh, venule and arteriole. So the constriction of venule and arteriole, these drugs that we injected, it is absorbed by venules to the venous circulation and then goes to the heart. When it is constricted and arteriole is constricted, then the blood flow will be less, and then this will not be absorbed. If it is not be absorbed, then the duration of action of this agent will be long and enhance intensity of nerve block. So when the concentration of this drug is high or remained high in the site that we are injected it, then of course the intensity of this nerve block will be increased and will be enhanced. So reduces systemic toxicity of local anesthetics. So systemic toxicity, it is the same mechanism as we talked about the prolonged duration, because it is constricted and less amount of these drugs will be absorbed or will be gone to the circulation. So when the level of local anesthetic is low inside the circulation, then toxicity or systemic toxicity will be reduced. Provide more bloodless fill for surgery, of course, is a good action because it can restrict the arterioles and venules. Then if we cut, we incise the area of surgery, the bleeding will be less. But something that I would like to add in this slide is this, that sometimes we should not use these anesthetics which are combined with vasoconstrictor in some area. For example, in the glands of children or in the tip of the fingers, okay? Or the patients with ischemic heart disease. These are not good because it will cause ischemia or even necrosis of this part. So order of sensory function block. So when we inject or apply the local anesthetic in the area, these sensory function will be blocked. Pain sensation, cold sensation, warm sensation, touch sensation, deep pressure, and motor. So if you have seen or if you see the patient who underwent or undergo spinal anesthesia, we do the procedure, he or she does not feel the pain, he or she does not feel the cold, he or she does not feel the warm. Sometimes uh, for this that he has a kind of chilling, but sometimes they put some warm dishes uh, on the legs of the patient and then they cover the patient. After 30 minutes or 1 hour, when we saw it, that there was a kind of burning on the skin of the patient. That is why, because the patient does not feel it, that it is warm or cold. And if you touch it, the patient does not know that where do you touch. And motor, the patient does not cannot move. If applied to the tongue, bitter taste test last first, followed by sweet and sour and salty taste last of all. But recovery in nerves uh, in reverse order will be in reverse order. So now we are talking about the uh, systemic actions of these agents. In CNS, all local anesthetics are capable of producing a sequence of stimulation followed by depression. We'll talk about this later, that which kind of uh, effects it produces in the central nervous system. But in cardiovascular system, local anesthetics are cardiac depressants, but no significant effects are observed at conventional doses. But at high doses, they decrease automaticity, excitability, contractility, and conductivity. As we talked that if we use local anesthetics with a standard dose or conventional dose, there will not be created any kind of problem. because we talked before that the patient who has some kind of comorbidities, for example, cardiac disease or respiratory disease, local anesthesia is safer than general anesthesia. So in this case, if we apply a higher dose of local anesthetics, then it will be more risky than general anesthesia. Then the local anesthesia for these patients are safe if we administer it in conventional dose, in a standard dose. If we administer it with a high dose, then it decreases the cardiac muscle and it will cause bradycardia, it will cause and low blood pressure and hypotension. And blood vessels also tends to produce falling blood pressure. Of course, the falling in blood pressure will be uh, due to sympathetic blockade or due to cardiac depressants effects. But higher doses cause direct relaxation of arteriolar smooth muscle. So in central nervous system, we talked before that first it produces excitement, then depression. First excitement, okay? When the dose is high, then the excitement be uh, will be appeared by tremors, shivering, and convulsions. And depression will be appeared by respiratory depression at higher doses, okay? But in cardiovascular derangement, high plasma tests may depress the cardiovascular system directly. As we talked before, blood pressure may fall because of arteriolar dilatation, myocardial depression, and our cardiac conduction disruption. Of course, we talked about it before. Treatment includes patient positioning, IV fluids, and vasopressor, of course. When the blood pressure is low, then we have to administer for the patient IV fluids and as well vasopressor because it causes vasodilation. Then we have to apply it for the patient. Hypersensitivity is another systemic reaction or systemic side effect of local anesthetic. As we talked before, that this allergic reactions will be low with amide local anesthetics, but will be high with ester local anesthetics. But when a patient has allergic reaction against one local anesthetics, he or she may have or may have not allergic reaction against others. So when a patient has an allergic reaction against lidocaine, it is not necessary that we say for the patient that you has allergy with the all other drugs. May have or may have not. So we can test it, we can check it. Okay. For example, if she or he has allergy uh, against lidocaine, then we will try bupicaine for him or her. Pharmacokinetics, it is we talked before in the previous lecture. We don't talk about this. So precautions and interactions. So when we apply local anesthetics, we should take care of these things, or we should be careful about these things. So when we inject or enter or insert our needle inside to the tissue, before to inject the anesthetic agents in the tissue, we should aspirate it because it will be inside the vein or vessel. If the blood is coming to your syringe, then it will be inside the vessel. If you inject in this situation, it will go directly to the circulation, and then high level of it will go to the circulation and will cause some systemic bad effects, especially cardiac complication and low blood pressure and falling the blood pressure. Even the patient will experience shock. So it is good that before local anesthesia, every local anesthesia that you do, you have to first aspirate it, then you have to have the IV line of the patient open. Okay, it is very good. Inject the local anesthesia slowly and take care not to exceed the maximum safe dose, especially in children. We should count the safe dose of our local anesthetics, especially when apply it for the children. Nowadays, circumcision is done by local anesthesia, by nurses, by other doctors, and so they should be careful about that. Yeah, choosing the safe uh, dose of these agents. Propranolol may reduce metabolism of lidocaine and other amide local anesthetics by reducing hepatic blood flow. So vasoconstrictor adrenaline containing local anesthetic should be avoided for patients with ischemic heart disease. I told before about this. Cardiac arrhythmias, uncontrolled hypertension, those receiving beta blockers or tricyclic antidepressants. So these patients should not take local anesthetics which has adrenaline inside it. We should inject for these patients, apply for these patients, those local anesthetics which does not have adrenaline. So now we are talking about the technique of local anesthesia. Surface anesthesia like this, that we apply NG tube, we apply endotracheal tube, we apply Foley catheter. So on that, in this situation, we use what? We use, of course, gel or pomade of lidocaine. Application of local anesthetic to nose, mouth, throat, or tracheobronchial tree, esophagus. Okay, esophagus when we apply in the gastric tube, it is called local or surface anesthesia. Okay, it is used to relieve itching, burning, and surface pain. For example, as seen in minor sunburns. Of course, we use these things because applying of NG tube, applying of Foley catheter well has a very low sensation of pain. That's why we reduce this pain, we reduce this bad sensation for the patient. We apply it at the surface of patient mucosa. So infiltration anesthesia is like this, that we block the local nerve in hair. It is used mostly in dentistry. Injection of local anesthesia directly into the tissue under the skin and used primarily for surgical procedures. Local anesthetics most frequently used are lidocaine 1%, bupivacaine 0.15%, etidocaine 0.5 or 1%, ribovicaine 0.51%, mipivacaine 1 up to 3%, and prilocaine 1 up to 4%. And we can mix it with adrenaline to prolong the action. Conduction block is like this, that we inject the anesthetic agents to the trunk of the nerve, around the nerve trunks. So the distal part of this nerve trunk will be paralyzed and will be anesthetized, and the patient will not feel pain, touch, and cannot move, and warm and cold sensation. Choice of local anesthesia and concentration is mainly determined by the required duration of action, of course. It is, as I told before, you see your procedure. If your procedure is a short action or short procedure, then you choose a short acting agent. If your procedure is a long one, then you select the long duration action anesthetic. Lidocaine for intermediate duration of action. I told before about this. Longer lasting anesthesia, bupivacaine may be selected. Bupivacaine is the best choice for long acting procedure, especially in spinal anesthesia. It is mostly used. Field block is like this, especially it is used in local anesthesia when we remove some local tumors or when we remove some local lesion of skin. So around the area that we do our operation or we do our incision or incise the patient, so we block like this, that around the area we inject uh, local anesthetics, and then the field of our intervention will be blocked by anesthetic agents. And nerve block is like this, that some 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 special nerve is blocked, like blocking of radial nerve, ulnar nerve block, or nerve block less than field block or infiltration anesthesia. So nerve block is, for example, radial nerve block. We just inject on the radial nerve. We inject over the ulnar nerve, okay? Or like penile block, that we inject on the penile nerve. And for this goal, lidocaine and bupivacaine can be used. All of them can be used because lidocaine is intermediate uh, duration of action, and bupivacaine is long duration of action. So epidural anesthesia is injected inside the epidural space. Epidural space. It is epidural space, and this is dura mater, and this is spinal cord. So we inject the anesthetic agents over there because the root of spinal nerve will goes from this side because it has some fat tissue, and then it will block the root of spinal nerves. Okay, spinal dural space is filled with semi-liquid fat through which nerve roots travel. Injected in this space acts primarily on nerve roots, and small amounts permeates through intravertebral foramen to produce multiple paravertebral blocks. This method is used to produce analgesia or anesthesia in surgical and obstetrics. This is divided into three categories depending on site of action. It will be thoracic, it will be lumbar, or it will be caudal anesthesia. So spinal anesthesia, spinal anesthesia, in epidural anesthesia, it is just injected over there, outside the dura mater. But in spinal anesthesia, we inject the agent in subarachnoid space in here, where the CSF or cerebrovascular fluid is circulating in here in the spinal nerve. So injected into the subarachnoid space between L2, L3, or L3, L4 of the spinal cord. Suitable local anesthetics like lidocaine 3 to 5%, bupivacaine 0.5, 0.8%, tetracaine 0.3, and 0.5% is used for this purpose. So the primary site of action in this method of or technique of anesthesia is cauda equina rather than spinal cord. Of course, it does not affect just the site that we injected. It affects on cauda equina. This technique of anesthesia is used to anesthetize lower abdomen and hand limbs. Nowadays, spinal anesthesia is an alternative of general anesthesia in most procedures, in most operations, which is done lower than umbilicus, even for nephrectomies, even for some procedure on the kidney. We apply local spinal anesthesia, especially for the patients who has high morbidity situations which threat the life of patients. So spinal anesthesia will be safer for this patient. So what are the complications of spinal anesthesia? Will be uh, respiratory paralysis. When respiratory paralysis will be occurred? When you inject the agent in high level, for example, L1, L2, or when you inject in L2, L3, but suddenly after injecting the agent, you lie the patient on the table. So in this situation, the the anesthetic agents will go high level than L3, L4, then L2, L3. Then it will go high level, then it affects the nerves which innervate the diaphragm. Then it will cause the paralysis of some muscle which takes part in respiration. It is very necessary that when we use these agents, you should be careful about that you use hyperbar or hypobar, because hyperbar will have a high density, it goes down, but hypobar, it is low density, it will goes up. Hypotension. Hypotension is because of vasodilatation and lower uh, extremity. That's why uh, circulation, most of circulation goes down to the lower extremity, and patient will be hypotensive. Headache because of CSF leakage, headache will be occurred. Cauda equina syndrome. Cauda equina syndrome is like sciatalgia or sciatic syndrome, and it will cause by some kind of pressure on spinal cord, especially by hematomes, and septic meningitis if you do not obey the rule for septic and antiseptic condition. Well, contraindication of the procedure is hypotension and hypovolemia. If your patient is hypotensive and hypovolemic, then do not apply this anesthesia for infant and children, because you cannot find the level of intervertebral space, then it is very difficult, and vertebral abnormalities and kyphosis are these are just a condition that you cannot apply spinal anesthesia. Thank you for your attention, students. It was our lesson about the local anesthesia, local anesthetics, and your homework will be this, that you have to discuss in next class, in open class, about the anesthesia in pregnant woman, which one will be safe and which anesthetics will be safe and which anesthetics will not cause miscarriage for the patient, because you know that acute appendicitis is emergent situation. If you apply anesthesia for this patient to remove the appendix, then which anesthesia is safe for this? This is your homework to read about this, and next class, open class, we'll discuss about that. And thank you for your attention. Our time is finished. and have a nice time. See you. Bye bye. Khuda Hafiz.